And hopefully that this will start conversations for greater collaborations with some of the wonderful work he's doing. Thank you.
Thank you. Thanks so much, Abdul. It's a pleasure for me to be here today. Well, I usually start that way. It's actually a little bit hard for me to be here today, let's be honest. As Abdul mentioned, I'm an alum and a faculty member here, which means that I was up very late last night, like the rest of you. So if I become incoherent at any point in this presentation, I hope you all will understand. It was a very long night. So, hello. This is going to be kind of fun for me because I was asked to talk a little bit about dissemination and implementation of digital health obesity intervention. So I'm going to give some kind of presumptuous thoughts about how we move this field forward, and I'm really looking forward to dialogue about it. I saw some of you. Does anybody remember these machines? Some of you are aging yourselves. That's okay. All right. The real nerds in the room appreciate it. We don't have to go back that far to kind of have a sense of how far we've come. Actually, much of, I think, the year 2007 was a really important mark in the sort of age of digital technologies, but particularly in digital health. Before 2007, if a patient came up to you and expressed interest in losing weight, you were very likely to recommend that patient go out and exercise or eat a little better. Or you might have suggested that patient work with a registered dietitian, or you might have said go to Barnes & Noble and walk through the 600,000 weight loss books and find one that works for you. You might have even said go and join one of the commercial programs. Some of you might have seen just yesterday a paper came out in Annals suggesting that Weight Watchers works really well, and indeed it does. In fact, none of us like to use Weight Watchers in our control arms because we can't outperform it. Nevertheless, these would have all been really good suggestions for you, for your patients. But the year 2007 was a very important year. Does anybody know why? Everything changed in 2007. No. What's that? There we go. There's the other nerd in the room. That's fantastic. It was the year that the iPhone was released, and really everything after that changed. I mean, it's actually kind of striking to think about how much our lives have changed since 2007. Before this point, not many of us carried our phones or were driving or walking while texting, but certainly after that, much has changed, particularly in the way that our patients manage their health. And nowhere can you see that change more profoundly than in the area of weight loss. Most patients, if you went out today and asked 10 people, are you losing weight? 9 of them would say yes. Most of them would have one of these apps downloaded on their phones, or would have a connected device. Fitbit's in the room. I can actually spot some of them as I'm looking around. So this was a big deal. And in fact, there have been over 165 million downloads of weight loss apps alone in the years since 2007. You see some of the top listed apps here. This is really just a sea change, again, in the way that patients think about managing their health and in patients' ability to access treatments. Now, it's a bit of an open question as to whether or not these approaches work, and we'll get back to that in just a second. So what I'm going to talk about this morning, again, is a little bit different for me because I do work in the dissemination and implementation of technologies, but mostly of the technologies that we create in our group here at Duke. But I'm going to talk a little bit more generally about just some of the data on the effectiveness of these approaches and discuss a bit about what kinds of design features lead these approaches to be more efficacious. And then I want to offer some thoughts from our work in dissemination and implementation to give you some ideas about how we move forward in this space. And a lot of what I'll say in that section of this discussion will be relevant to areas outside of the obesity space and will really apply to digital health more widely. So let's start with some level setting. I'm going to talk mostly about trials and studies that are more than 6 months in length. What's happened in maybe the last 3 or 4 years is that there's been a surge of pilot trials that have looked at one app or another, but most of those have been relatively short duration. The key challenge in obesity treatment is the long duration that's required to produce clinically meaningful outcomes, and then importantly to keep patients weight loss maintained over a long period of time. Most of us joke that we could get most patients to lose weight in 6 months. The real challenge happens between 6 months and 1 year. And if you look at almost any trial in the more general obesity treatment space, almost every dietary approach or intervention works to produce weight losses at 6 months. The real challenge is after that point. So that's what we're going to focus on here. And you should know that this area of science is one in which heterogeneity abounds. There are a variety of different approaches, different types of apps, different types of connected technologies, inclusion of a coach, lack of a coach, who that coach is, all kinds of things. And what I'll get to at the end is that where I think the greatest opportunities in this space exist are in this area of sort of standalone trials. Most of us exist in a world in which we download an app and then use that app for some amount of time, but there are actually very few trials that have looked at that question. So we'll come back to that in a bit. Here's your take home. I'm not going to bury the lead. At 1 year, most of these approaches produce about 2 to 4 kilos of weight loss. And weight loss in excess of around 5 kilos has almost never been demonstrated. So a 1-year weight loss of about 7 to 9 kilos is what you'd see in a really well-designed clinical trial, weight loss trial. So this is about 2/3 of what you'd see there. And I don't know if this will surprise you or concern you. It sort of does both for me, but this is about what you see. And like I mentioned, though, heterogeneity abounds. This is still a young field. There just haven't been a ton of approaches tested. Now, I want to apologize to any biostatisticians in the room because this is actually not a forest plot. This is what I call a gist plot, and it is designed to convey the gist of lots of different trials, okay? I always see biostatisticians, bang their hands on the table and walk out of the room. I'll know you if it's you. But nevertheless, the point here, what I just want to convey is what I just mentioned. With the exception of only really one study in the last decade or so, if you look at trials that compare technology arms to non-technology arms, so these are often behavioral weight loss treatments that happen in person or group. You see most trials generally produce, and these are statistically significant outcomes. You generally see that most trials exist in that 2 to 4 kilo band. These 2 blue dots represent trials of 3-arm trials. And in general, this is about what you get. So you're not going to see much more than 4 kilos with these approaches at 1 year. These are trials that compare technology arms to less intense technology arms. And again, you're mostly in that 2 to 4 kilo band. That's about what you're going to get from these kinds of approaches. And again, this is not, this should be concerning if your goal is to try to use these approaches on their own to produce clinically meaningful outcomes. But what I'll get to in a second is that their ability to produce outcomes as adjuncts to other types of clinical strategies, I think, is where most of the action is. So you may say to yourself, there are lots of different digital health approaches that we can use. There are web-based approaches and apps and text messages and interactive voice responses, and we build all of those in our work here in our lab here at Duke. But nevertheless, you would expect some of these approaches to operate differentially. And actually, the answer is that at this point in the literature, which again is only about 10 years old, we don't see much variability. So back to this gist plot. I hope nobody steals that term. I love it. The gist plot here. If you just, it's a little hard to see for those of you in the back, but nevertheless, what I've done is put icons in here that represent the different types of technologies that have been tested. So we have apps and email and desktop web-based approaches and combined approaches that include web-based approaches and telephone counseling. And in general, you're going to get 2 to 4 kilos no matter what you do. So this is an issue, but nevertheless, the field is young, and we generally have a literature that's really dominated by web-based approaches. We're seeing a surge of text messaging-based approaches and increasingly IVR-based strategies. I'll talk about both in just a bit. I'm quite bullish on text messaging-based approaches because of their potential for reaching very large populations. Apps are constrained in many respects based on operating systems and geography, but text messaging has great potential for population reach, and we've demonstrated that both in the United States and increasingly in China. So one of the studies I want to talk to you a little bit about is BeFit BeWell, and the reason that I mention BeFit BeWell is because you generally, if we have not really seen comparative trials that have tried to test head-to-head one of these channels against another. So we can't say with any confidence at this point whether an app works better than a website or a website works better than text messaging. Those types of comparisons just haven't been done as of yet. I think the closest you get to it is one of our studies in BeFit BeWell. And BeFit BeWell was a pragmatic trial that we conducted in Boston Community Health Centers a couple of years ago. The point here was to try to identify strategies to optimize the behavioral treatment of obesity in the clinical setting. And so we did a 2-year clinical trial. Again, this was a pragmatic trial. We had very few exclusions. We took referrals from a variety of different settings, and we really tried to minimize barriers to patient participation. All of our patients in BeFit BeWell were hypertensive, and there was a sort of a secondary interest in the intervention in self-management. And again, we were very, very concerned about this question of dissemination. So we randomized almost 400 patients to intervention or control. And where things got interesting, I think, in BeFit BeWell is that we allowed our participants to choose whether they wanted to interact with the intervention via a website or via interactive voice response. Interactive voice response is like an automated telephone call. If you think about, when you're calling your bank or you're calling your airline, it's usually the system you're very angry at and you're sort of cursing at. In fact, you should try cursing at an IVR system, because we and others use algorithms that if you happen to use expletives, you get right to the operator. True story. It's true. So nevertheless, we allowed patients to choose. And the reason that we allowed patients to choose in this trial is because we were working in community health centers in an extraordinarily impoverished group of people. So average age was about 55, black women, low education, in poverty. These are not people who were necessarily concerned all that much about weight loss. And so our interest here was in trying to design technologies that would have the broadest reach. This was our website. Please don't judge me on it. It was a couple of years ago. And in our interactive voice response, or our automated phone technology arm, we gave people little tracking logs like these, which had stickers, and they could kind of keep track of things, and they got a telephone call once a week. They could speak to that telephone call and track how well they were doing with their goals. All those data were then aggregated, and we used those data and we pushed them there to their providers to help the providers to better counsel patients in the clinical encounter. What you see over 2 years is what we think was an interesting pattern. Basically, we didn't see large weight losses, but the weight losses that we did see were sustained. So as I mentioned before, the classic sign and the classic sort of image in most weight loss trials is maximal weight losses at 6 months with rapid weight gains up to 1 year. We didn't see deep weight losses at 6 months, but the small weight losses that we did see were maintained out for 2 years, and that makes this notable in some respects. But if you ask me really, how much I care about obesity as a weight loss as an endpoint, I'll tell you, I don't really care about it that much. I'm actually much more interested in weight loss's effect on cardiometabolic outcomes. And so some patients will lose a lot of weight and demonstrate improvements in cardiometabolic parameters. Some patients will lose a ton of weight and see no impact on blood pressure and lipids. I'm much more concerned with the former group. So what happened in here was notable because we prevented progression in this group of hypertensive, obese patients, again, who are quite impoverished and whose blood pressure was not well under control. So we had about rates of around 40% of control at baseline. And so you should see basically progression in particularly systolic blood pressure, which I'm showing here, over that 2-year period. And in fact, what we saw was a prevention of that progression. Lots of other interesting outcomes: increased odds of blood pressure control, better medication adherence, actually quite high rates of medication adherence, better sodium intake, increases in physical activity. But the reason that I want to point this out is because of this question of self-monitoring. So the real cornerstone to all behavioral interventions of this type is self-monitoring. What you see study after study is that patients who are able to track consistently do better. I'll talk about this a little bit more in a second. And so the real question is, do you see differential outcomes depending on what kind of technology channel patients use? And here we did. In fact, patients who used that automated telephone call did much better over that 2-year period, i.e. they took more of those calls than did patients who used the website. So much lower rates of website logins relative to interactive voice response. But that's really only part of the question. The other issue is that our IVR users were less likely to stop using the intervention. And in weight loss, most self-management interventions, all behavioral lifestyle kinds of treatments, the key issue is who's going to stick with you for enough time to see improvements in the health outcomes that are of interest. And here what we see is that patients were able to stay involved much longer. But things got even more interesting in BeFit BeWell because we allowed patients to move from one channel to another. So that is to say, if for some reason you were using the web and your web access went out or you weren't able to pay for it anymore, which happened all the time with these patients, we wanted you to be able to move to the other channel so people could move back and forth. Just as most of us would log into Facebook and on our mobile phones and then pick up our iPads and then move on to our desktop or our laptop computers. And so what we found was that everyone moved from web to IVR. Of course, they could move back and forth, but everyone went from web to IVR, which suggested to us that there were challenges with access in this population, which would not be that much of a stretch. But there were no demographic clinic, or we used lots of robust algorithms to predict participation, and we saw no predictors of this movement with the exception of low web engagement. So that is to say, the only thing that made you move was the fact that you had some difficulty logging into the web over a long period of time. And importantly, though, and I think the take-home point, is that people who did switch were the most likely to stick with the intervention for the 2-year period. So that is to say, you give people options, you give them a variety of channels that they can use that accommodate their needs, and they'll stick with you. And that's become a principle in the work that we've used. Because again, the key challenge in these types of interventions is engagement. There's really nothing more important than engagement. And our sort of key finding in all of this literature is that when patients use more, they lose more. So engagement is easily the most reliable predictor of outcomes. In the old days of weight loss treatment, and when we would have patients monitor everything they were eating and drinking on food logs, i.e. we would give them, just basically big tables, and they would write in everything that they were eating and drinking over the course of the day. Many studies showed effectively you didn't have to look at what patients were writing down. All you needed to know was how many food logs they turned in. That was the best predictor of outcomes. So engagement is really critical. The problem is that if there is a law in digital health, the law is the law of attrition. People stop using over time. And so the key challenge is how do you get people to stick with these kinds of interventions? Lots of different engagement outcomes have been used in this literature, and I'm not going to spend a ton of time talking about them. They all get to the same point, which is ongoing utilization and engagement with the intervention content. But you can see how important this is I think in one of our studies by a colleague, Bonnie Spring, who's at Northwestern, who did a study basically trying to look at a mobile app, ancillary mobile app, that she wrapped on top of VA's very successful MOVE weight loss program. Some of you know MOVE. MOVE is a bi-weekly counseling intervention, about an hour and a half a week. You get a 5 to 10% weight loss goal, and you have these bi-weekly weigh-ins. So you come in, you work with your group, and you get skills training along the way. And what Bonnie did was to add an additional arm that gave patients a PDA. So basically sort of an old Palm Pilot kind of thing, and it really was an old Palm Pilot kind of thing. And so this had a kind of a thermometer decision support. So as you were tracking more, it would suggest that you're not doing so well with your diet or with your physical activity, and your thermometer's looking a little low, so you need to do a little better. So it gave a bit of a visual kind of a reinforcement for how well patients were doing. And then she had them come in for biweekly behavioral counseling. And effectively what you see here is that if you look at attendance rates, in fact, what happened is that the patients who used the mobile app did better than patients in standard care. But the real action was for patients who used the mobile app and stayed engaged. So if you looked at folks who attended more than 80% of their MOVE sessions, so this is outside of the app, and they also used the app, they had much larger and much more durable weight losses at 1 year. So this issue of engagement is really critical for many of us, and in a dissemination and implementation context, it gets even more sticky. This is a study that we recently completed called SHAPE. The basic background to SHAPE is that weight loss is only one part of comprehensive obesity care. One needs to think both about weight loss, but also weight gain prevention. Not every patient wants to lose weight. In fact, I think most patients don't. The estimates are around 30 to 50% of patients present who are obese, who may receive a recommendation that they lose weight, but they have no expressed interest in losing weight. And the question is, what do you do with all of these patients? The real risk I think from a health outcome perspective is both obesity, but in middle age, and particularly for women, the real challenge is weight gain. Many patients will gain 1 kilo to 3 kilos a year during that period of time. So if they don't have expressed interest in weight loss, then it's the weight gains that are going to get them rapidly to morbid obesity and to a whole cascade of cardiometabolic challenges. So our question has been, again, in an implementation context, in real-world health practices, how do we keep patients in midlife from gaining weight when they have no interest in weight loss? So we started this trial here in North Carolina in about 8 clinics in rural North Carolina, called it SHAPE. And these are women who we recruited who were middle-aged, had no expressed interest in weight loss. In fact, many of them were quite opposed to weight loss for a variety of reasons that I'm happy to describe if you're interested. But we did this trial in black women, and we did this in black women for 2 reasons. One is that is the excess risk of obesity. Black women have the highest rates of obesity in the US, health complications, least likely likely to be treated, et cetera, but also because obesity has dramatically fewer health consequences in this range of BMI for black women than it does for white women. So that is, to put it another way, at slightly levels of sort of slight obesity, just over the obesity threshold, the risk of hyperlipidemia and hypertension are dramatically lower in black women. So it's a bit safer to do this work, at least in an efficacy context, in this group of women. We did it in an effectiveness context in primary care. So in SHAPE, what we did was a very, very simple intervention. We just had women, they got these weekly interactive voice response calls. You get a telephone call at the end of the week. What we do behind the scenes is that we recorded thousands and thousands and thousands of hours of essentially automated, we have voice actors sit and record these thousands of hours of conversation. And we then cut up these voice files. And then using our algorithms, we can piece these voice files together so that it sounds like you're hearing essentially a counselor ask you to self-monitor your data. And then we give feedback for every time that a patient has reported something to us. So you may hear a telephone call that says, hey, how are you doing on your 3 SHAPE goals? Patient reports their SHAPE goals either via voice or through the keypad, and then you hear tailored, very personalized feedback that corresponds to how that patient's been doing, what their goal is, what the provider's goal is, and all of that happens in real time and with these voice calls. So we do all of that, and then we grab all the data from the self-monitoring, for these self-monitoring events, and we push these data into the clinic, where providers can use them and where our registered dietitians can use them for coaching calls. So a very simple, very straightforward intervention. The intervention was 1 year in length. And so what we're looking for here is the prevention of weight gain, because we should expect in an untreated population to see weight gains of around 1 to 3 kilos per year. We saw something less than that in the control arm, but nevertheless, we saw the prevention of weight gain here in the red group out 18 months. That was great. So our intervention participants did start out, were twice as likely to be at or below their starting weight at 18 months. But the real action, I think, happened 4 years later. So we went back recently and did chart reviews of these women. Again, this is sort of in a pragmatic trial context. And we identified all the intervention participants. And what you see is that this 12-month simple intervention prevented weight gains out 4 years. So we were successful in the goal of trying to keep these patients from gaining weight when they ordinarily would have, which we see indicated here in the blue line in the control arm. But the point here, again, is in this idea of using more and losing more. We really designed this trial to be simple. Patients are holding their phones. They're in their pockets all the time. What's the average number of times that you will check your phone in the average day? Anyone? I see, every time I ask that question, people's heads just go down. They turn red. How many times a day do you pick up your phone to check it?
120.
120. Oh, Monique, that's really depressing. Really, really depressing. And actually, no one else is speaking because they all are doing twice that. That's pretty much it. The answer is 150 times. 150 times a day. If you actually want to feel horrible about yourself, download this app called Moments. Moments app, install it on your iPhone, and you will feel horrible about yourself. Gives you this little alarm. For me, I set it around 100 checking times a day, and it just starts buzzing, and my kids say, Daddy, Daddy. But the idea is that you're constantly holding that phone in your pocket at all times. And so the idea of getting a telephone call is actually an approach where you can demonstrate a lot of reach into populations, in our case, that are historically disconnected. These are folks who we have not generally thought of having the kind of access that we use here. So we get about 72% IVR call adherence in SHAPE, meaning that they pick up this phone call 72% of weeks over 1 year, and 85% adherence to their coaching calls. So that's actually pretty good. Incidentally, if you show this, the apps that have the most amount of utilization are games. And games have about somewhere between a 10 and a 15% rate of engagement out for 3 weeks. That means that you'll use them each week. You just open it each week. 10 to 15% of the time, patients will open it once a week over 3 weeks. If you can do that, then you can get a lot of money from venture capital folks to help you to make your game app. We vastly exceed that in most of our trials. It's not just us. Almost all of my colleagues are able to exceed this in most of our trials. And this is an area where we're beginning to work and beginning to leverage some of what we're learning and kind of in the behavioral analytics that power the engagement strategies that we use. And we think that this is a place where we really can make some headway. But again, what I mentioned to you here was that these are patients who are not who are not interested in weight loss. And nevertheless, the patients who have the highest IVR use, here are 80% of call weeks, so these are folks who pick up their calls greater than 80% of the time over that 12-week period, they actually lose 2 kilos. Now, these aren't patients who want to do that. Now, this is important only because the most amount of weight loss that's been demonstrated in black women at 1 year is about 4.5 to 5 kilos. So you get about half that in patients who don't want to lose weight just incidentally, if you can keep them engaged. So the key challenge in this space, and I think the conundrum for all of us who do this work, is that these approaches work better when there's a human involved. So lots of us get very excited about the promise of technology, but actually, really what technology does is it charges up effects that happen in the clinical encounter of one sort or another. And so the classic finding is that if you add a behavioral counseling, you'll do better. Again, I'm going to show you one of my GIST slides in a second, but let me point out a classic trial by my colleague Deb Tate, who's over at UNC. And this is one of the first studies of its type, but basically what she did was to give people basically a basic internet intervention. You see the description here. This is pretty much what basic internet interventions look like. You get a calorie goal, a physical activity goal. You track all your diet and physical activity here on the technology on the website. You get tutorials and message boards, and you get this weekly reminder to self-monitor your weight. Or you get everything, and then you're also tracking your diet and physical activity via the web. You're taking daily diaries. You get email counseling, which is really the key thing. The registered dietitians here are emailing you saying, how are you doing with your goals? Here's some strategies to do a little bit better. Do you have any questions? You get 5 of these in the first week, and then you just get 1 a week for the next 11 months. Just that email contact, and that produces a clinically meaningful amount of weight loss and dramatically different than what you see in just the basic internet only. And so that's a really low bar for behavioral counseling attention. And you know, some of you may say, well, what do you get? There are lots of different approaches for doing this. You may have patients come in for an individual encounter. You may have a group session. You may have group telephone counseling calls, which happens occasionally. You may have individual counseling calls like the ones we use. And in fact, you generally see similar outcomes no matter what you use. This is a study by Larry Apple and colleagues up at Hopkins. And they did a trial, actually, that this BeFit BeWell that I described to you before I was part of a U01, so kind of a connected set of trials in primary care, and Larry's group was also doing one of these. So this was in primary care in the Baltimore area, and they had 3 arms. They had a control arm, an untreated arm. They had a remote support only arm, which I'll describe in greater detail in a second, or you came in as you would traditionally do, kind of a gold standard behavioral weight loss intervention. All the patients got a 5% weight loss goal. All of them had access to a website, and all of them got weekly progress emails. The real distinction in the 2 arms was whether you got a telephone counseling call from a registered nurse at Healthways, a large disease management company, one of the largest in the country, or whether you came in for your treatment and you received counseling from a member of the study staff. And effectively what you see is that at 24 months there was no difference between those 2 arms. So you can get your calls on the telephone, you can get your counseling in person, and you can imagine that the cost profile of these 2 different approaches, particularly given the scale of Healthways, is really just an order of magnitude different. Again, back to my GIST slide, you see there have been lots of different approaches tested. They're all 2 to 4 kilos. That's pretty much what you're going to get. That's your take home. We do know that connected devices can improve outcomes, although the magnitude is sort of how much. So I know, again, many of you have Fitbits on and probably view these as a primary weight loss strategy. There's really only been 1 or 2 trials on this topic using a bit of an older fitness device, the Body Media device, which is actually a great device. It just looks like one of those armbands you get when you're discharged from the jail, which I really know nothing about, but nevertheless I've seen it on TV. And basically what you see here is that if you receive standard group treatment and you're also using this Body Media armband, you see dramatically greater weight losses here at 9 months. We see similar kinds of effects in a way that I'm about to show you in just a second. But the basic take home here is that with a basic intervention, you get an additive effect with these kinds of devices. We don't really know whether or not you get a primary effect. Challenge in all of this, self-monitoring declines. Patients stop becoming engaged. And the question for us has been in this device space has been, are there other types of devices that can do a pretty good job of keeping patients engaged? Now, I show you a scale, and most of you are thinking, how on earth can a scale do a good job of keeping me engaged? I actually want to avoid my scale most days of the week. And many patients do feel that way until we start to talk to them about data like these. So if you think about, from a behavioral perspective, if you think about me giving you the goal of tracking a behavior every day the right way for up to 24 weeks, you may come back to me with a couple of different patterns. You may have something like a high frequency pattern where you sort of track 3 or 4 days and then you stop tracking, and then the next week you track all 5 days, and then you stop tracking, and then you go back and it's 2 days. So it's kind of a high frequency. Over 24 weeks you've actually tracked a lot, but you see these peaks and valleys over time. You could also have more of a consistent kind of a pattern where you're tracking 3 days every week consistently for those 24 weeks. And if you ask me which one is better, which one is most important from the perspective of weight loss outcomes, the answer is consistency. So consistency outperforms frequency, or the raw number of times that you tend to self-monitor, and it's more important than detail. People ask me all the time, with the kinds of approaches do we use, do you care what people are saying in your self-monitoring? Do you care how many fruits and vegetables they're consuming? Do you care how many steps they're getting? And the answer is no. I don't really care at all. What I really care about is whether they'll continue to give me those data over a long period of time. That tends to be the most important piece. And so in this study we call WAY, my colleague and now postdoc and now faculty member here, Dory Steinberg, did a really, I think, very novel and I think will be a seminal study, where she asked patients to weigh themselves every single day. She gave them a network-connected scale. It speaks to the sky. We can see the weights. And she said, weigh yourself every day. And then she very simply gave them email feedback at the end of the week and some graphs that said, here's your weight loss trajectory over the course of the week. You're doing a good job, great job. That was really it. It wasn't super sophisticated. She gave them these kind of very basic behavior change lessons that are the kinds of lessons you may see online at NHLBI website or AHA website. But she didn't tell them to monitor diet or physical activity at all. Just stand on that scale and weigh yourself. And what you see is over 6 months, patients lost 7% of their body weight. 7% of the body weight is from an obesity. I can see obesity people in the room because your eyes just got really wide. 7% of your body weight is a huge amount of weight loss to produce in a 6-month period of time. It's almost the amount that was produced in our largest gold standard obesity trials, those that many obesity scientists look to as being evidence, sort of emblematic of best evidence. And so just standing on the scale each day and getting this little bit of feedback produced this amount of weight loss. And the real reason for this, we think, is because of this persistent engagement. So if you asked me, how often do people actually stand on the scale? The answer is they stood on the scale almost every day if they were in the intervention group. So the control group also got access to the scales, but they weren't given an explicit recommendation. They were just given the scale, and we said, just do with it what you will. And basically what you see is that it came out neatly to be almost the comparison between a daily and a weekly recommendation. If we were in a control arm and we just gave you a scale, you stood on it about once a week. If we gave you the scale and we told you to weigh it every day, you weighed 6.5 days. And over that period of time, if you weighed 7 days, then you were really driving the weight loss effect. You lost a dramatically greater amount of weight than if you weighed fewer than 7 days. So the take home here in this space is that these kinds of approaches, these connected device approaches, can be extraordinarily powerful, provided that they're able to get patients to get them engaged and get them to stand on scale or track themselves each and every day, which is really the key for these behavioral interventions. And you can produce clinically meaningful outcomes with relatively low intensity types of intervention approaches. Many of you are wondering, though, what do we know about weight loss apps? MyFitnessPal, Lose It, and the answer is almost nothing. These approaches generally have not been tested in really well-designed, robust trials. That's why I saved it to the end. I really did bury my lead. The best thing that we know here is that you can get about 3% weight loss at 1 month with Lose It. That's really the best evidence that we have in this space. It's just a 1-month trial. I hesitate to even say it because I'm not sure that it's certainly not clinically meaningful, and we're not sure that it's really durable. A lot of us are excited about apps because so many of us are using these technologies so frequently. Last year we had this interesting crossover where our use of mobile apps began to surpass our use of desktop computers. And that's a really exciting sea change for us. But nevertheless, there are lots of problems. And I call this, from a dissemination perspective, the rule of 70. So most users, 70% of users, don't download any new apps in a month. Take a given month, most people do not download new apps. And when they do, most people don't use them very often. So most people, 70% of people, launch their app one time, their brand new app one time. And if they do launch your app and they do use it, they won't use it for very long. 70% of use time is spent in 3 apps, and I bet you can name them. What's that?
Google Maps.
Google Maps. Not me, and that's my wife's concern.
Text.
Facebook?
Instagram.
Instagram? No, but that's a good one. That's Twitter. Third one? ESPN.com. No, it's not. New York Times. 3 apps, 70% of your user time. That's it. So that's your problem. So that's a real challenge for those of us who are thinking about how to roll these apps out. Now, it's also the case that these apps lack a lot of evidence-based components. So many colleagues now have done studies like this where you go back and you look at all the apps on the App Store and you count how many evidence-based components the apps include in them. So this is my colleague Sherry Pagato, who is at UMass Medical Center, and she went in and she compared many of the leading apps in the App Store to the Diabetes Prevention Program trial, which is what we think of as a gold standard weight loss trial. And what you see here indicated are the percentage for which the apps included these components from the DPP. And you don't really need to get into the detail here. You only see that the top 3 are only those that are in excess of 20%, a weight loss goal, a dietary goal, and calorie balance. And then you pretty much drop off. Most of the apps then just don't include the kinds of components that we think constitute an evidence-based program. Real problem, like nutrition label reading, none. It's really kind of a concern for many of us. So if you ask me what's required, what do you absolutely need in these apps, I would say you need some way to self-monitor, you need some way to give people the skills that they need to change their behaviors, and you need to provide some type of interpersonal support. There's not really a lot of criticism around those 3 things. That's pretty much, most of us agree with that. But you can see there's lots of other gaps that we need to sort out. So I'm going to spend just a couple seconds here talking about getting it out there, because I think the getting it out there is the real challenge for us right now. I think right now we're sort of in a place where, maybe 2 or 3 years ago, where there was no evidence in this space. And now we're increasingly are getting to a place where I think there's insufficient evidence here. Right now, if you look at many of the leading websites that do weight loss, you'll see evidence like this, which I know you can't see, and that's okay. Just trust me, it's crazy. There's lots of very strange claims here about the amount of weight loss that people have lost, and they use conveniently, most patients want to lose around 20 pounds, and so conveniently everybody's in excess of 20 pounds. This is really not well-designed evidence. So, I'm hoping that we move to generation 3 where we have evidence apps that are based on evidence, and indeed we're beginning to see apps like this. One of my favorite in this space is the app from Omada Health that's called Prevent. And these are guys who basically have developed an app that does the diabetes prevention program, again, what we think of as a gold standard weight loss app for patients with diabetes. And what they do in this is basically an online group session. It's really well done. It's quite adherent to the diabetes prevention program, and they're very serious about this. And that's the kind of apps that are based on evidence that I think we'll begin to see more of in the next year or 2. There have been lots of acquisitions in this space increasingly, and you're seeing many more people clamoring for this type of evidence. But I don't really think that's sufficient. I think what we really need are research-tested apps. So these would be apps that are based on evidence but actually have some data behind them, trial data that suggests that they work. The Omada Health app does have some trial evidence, but it's relatively short-term. It's impressive, but it's short-term. And this is really where we need to go. But our challenge in getting there is our translational pipeline. I know many of you have seen slides like this, and basically the take-home here is that if you do this the way that we argue it should be done, we take you through design, efficacy, effectiveness, sustainability, scale up, and then we really roll it out, this whole thing is going to take you about 17 years. And lots of people quibble about this number. Is it 17 years? Is it 12? Is it 15? Is it 10? I'd argue if it's anything with an error of around 5 years, around 17, we have a real problem. Because, with my industry hat on, we can go from nothing to an app in about 3 months. And I have been involved in many startups in which we basically go from idea, napkin, to app that has paying users in 3 months. So the idea that it would take you 17 years to get an evidence-based approach into the market just means that we won't be there. And our market and our patients will be continuing to use approaches that are not tested. So to get there, I think we need to do these things. The first thing is that we need to focus on the right adopter. So who is going to use these types of interventions? I think I've already argued that the rule of 70 means that direct-to-consumer isn't going to work for most health apps. If you today put together a great napkin and find a great set of programmers and put an app out, you are pretty much guaranteed that no one will use your app. That's pretty much what the data suggests right now. So it would be a really bad investment of your resources. Instead, I think you need to be focusing on where are the niche groups, where are the settings, where are the places where you can begin to get your app integrated and that doesn't involve a direct-to-consumer kind of involvement. Key for dissemination research in this area. But the problem is that in digital health, our adopters are not often our settings. So the way to say this is that if I think about the kind of stakeholders that I would want to involve to do a trial, I might think about the health system leaders, I might think about providers, I would think about patients. These are the people I'd need to talk to do a trial of one of these interventions in, say, a health system of some sort. The problem is that it's often those constituencies are not the people who will ultimately adopt or buy one of these types of interventions. And the reason for that is that they're just not ready-made to support them. In fact, the kinds of people who adopt or who purchase these kinds of interventions tend to be groups like these. They increasingly are EHR, HRA vendors. There are a lot of the wellness vendors, patient portal makers, the disease management companies like American Healthways that I talked about before, lots of weight loss startups, established weight loss vendors. One of our leading obesity researchers is the chief science officer at Weight Watchers, and he's been buying up companies like this like crazy in the last 6 months. And the reason for this is that these are the companies that have the kind of scale to create the infrastructure to leverage these digital health interventions. So when we're doing D&I research, dissemination and implementation research in this area, it's insufficient to think about the health system considerations, because those are often not the ones that will lead these interventions to actually be successful with real patients. One way to describe this is with BeFit BeWell. Made a big deal about it being focused on dissemination, and one of your questions maybe is BeFit BeWell disseminated? And that answer is no. No one's actually using it right now. It sits on one of my computers. And the reason for that is that we didn't do a good job thinking about who the adopters were. We assumed that it would be the health system. We thought it would be the health centers that were the ultimate places where we disseminated this. But in fact, that made no sense, because from the perspective of the health centers, they have lots of community health workers running around who would be available to disseminate these types of interventions. But they were uninterested in us being able to use community health workers for this study because we can't reimburse for community health worker time. So it just didn't make sense. Instead, if we thought about disseminating to a disease management company, we would have designed this with nurses and health educators delivering the intervention instead. Those are places where they can get reimbursement for delivering these kinds of interventions. We assumed everybody would keep the same coach over 2 years, a silly assumption in health systems like the one in which we work. Disease management, we would have made no such assumption. Primary outcomes. We thought weight was the most important outcome. It's not the most important outcome from the perspective of disseminating an intervention like this. Things like satisfaction, cost, weight as a tertiary outcome, productivity, presenteeism, absenteeism, quality of life, those kinds of things are ultimately much more important in a dissemination context. And we had no evidence about that at all. And so there was a massive amount of disinterest in adopting that intervention. And then I think one of the questions we want to think about is, do we really need an app for that? There's only one thing you can say about digital health, and that is that the field moves very, very quickly. There's lots. I have a closet at home that's full of lots of great new innovations. All new innovations will basically enter into that closet at some point. And so the question needs to be, do we really need an app for that? I think the answer is no. I don't think our time is really well spent building a lot of apps. And we've been spending a lot of time in the last couple of years repurposing what we do and thinking much more about the cloud. The reason for that is if you take any one of our interventions and you kind of run it through the meat grinder, what you're left with are lots and lots of algorithms, content libraries. I mean, I have terabytes of voice files and different ways of saying good job and great job. We call them attaboys and attagirls. That ultimately is what you want to disseminate, not the app. So we can put that in the cloud and let people use it in a variety of ways. That's what we're doing right now with something we call the IOTA API. I won't get into IOTA, but basically know that we are putting an evidence-based weight loss intervention into the cloud, making it publicly available for people to integrate into apps of any type, whether you want to make an actual app or whether you want to make a phone app or desktop kind of a website, anything like that. And that's really where I think most of the action is. It's just too challenging for us to figure out how to make apps stick when we're working on an R01 budget. That's the third consideration, making it stick. This cannot be done well. Most of us, in the old days, we would go to places like, I used to go to this store called Babbage's, which was in the mall, and you'd go into the store and you'd see a big rack of new software. Does anybody remember this? And you would pick off a piece of software. None of us get our software that way anymore, right? We get this little indication that we have a new software waiting or an update waiting. And there's a really good reason for this. That's because most of my colleagues in industry have a mantra. It's called release early, release often, and iterate. The idea is that you'll learn more about the strength of your app and how to develop it by getting out a minimally viable product, something that just kind of works. It meets the needs of your user base. And then you look at how people use your app. And then you continually integrate new features. And what they know is that every time you see that little light on your iPhone that suggests that you have a new update, it's a good indication that you ultimately are going to open that app again. When you get new features and new enrichments, you're more likely to use that app over time. It's one of the ways that my colleagues make these things stick. And so real-world digital health is all about change. If you look at many of the apps that you're using, Facebook has changed 4 or 5 times in the last year. They update every month on a routine schedule. And that's a really key idea to keep you engaged. I like to show data from the Obama election to illustrate this point. The Obama team was really good at design. And what they did were lots and lots of studies to try to figure out how to optimize people's likelihood of giving a donation. So here, what they want you to do is to basically have dinner with Barack. And the way that you do that is by entering in information there and clicking that Get Started button at the top. So the first thing they do is they show you this little image of the president. And then they show you an image of you imagining yourself having dinner with the president. And just showing that one image change produces an almost 20% increase in the number of clicks that people use. One day during the Obama campaign in 2011, they tried lots and lots of different subject lines. Anybody who got emails from the Obama campaign will remember lots of the subject lines that you got. This is nonpartisan talk, but nevertheless, it illustrates a good point, which is that they just kept rotating these subject lines over and over and over and over again. So one day, June 26, 2011, they rolled out all of these different subject lines. They randomized people to receive these different subject lines. The body of the email message was exactly the same. The only thing that was different was the subject line. And what happened? Massive differences in contributions. When I say I will be outspent, they got $2.5 million from that one message alone. But if you say, I'm thankful every day, that doesn't work at all. Right? This shows the power of design and of user interface. And the point here that I want to make, and just incidentally, they made a lot of money that day. The point I want to make is that when you're really designing an app in a real-world setting, what you would do is this. You release an app like this, and then you'd say, the goal here is to have a patient hit call your coach. That's what I really want patients to do. Well, patients aren't really hitting it, so I'll try making that button red. I'll roll that out and see how they do. And then maybe if I find that they like to hit the red button, then I'm going to try to, maybe I'll say, well, maybe I'll split it up. Maybe I'll give an option to text, so I'll try that. I find that the red button really works the best. So then I'm going to make all my buttons red, and I'm going to change the tagline. Instead of call Jenny, my coach, I'm going to say get support now. Something very action-oriented. That sort of works, but now I really want to give people the ability to get reminded later if they can't call right now. So they have an option to hit now, or they have an option to hit remind later. And that works the best, and that's what I go with. That's how it's really done, and this can result in massive differences in engagement and in stickiness over a long period of time. And unfortunately, that's just diametrically, I'm just going to skip ahead a little bit in the interest of time, that's diametrically opposed to the idea of the randomized controlled trial, which basically says, you've got 2 pills. Pill A, the real pill, the intervention pill, and your placebo. I've pressed them in the factory, they're the same pill, they're going to exist the same way no matter the duration of the trial. You're going to take the same exact pill every single day. So I can very confidently randomize you to one arm or next. That's just not the way that you do this in digital health. In digital health, when I do an RO1, I release one version, my version 1. I design it, I test it, 4 years. Crazy amount of time. Nobody will ever use it. Or I compare this to the way my friends in industry do it. They may release 10, 15, 20 versions in the first year alone because they're constantly developing, they're constantly testing. And so I think that the fact that we don't do this, the fact that we don't use these kinds of principles in our trial, suggests that, this is my big dramatic moment, I think our effect sizes are actually larger than they may appear. The fact that we get 2 to 4 kilos and we're just releasing version 1s and they're ugly and they never change and we don't consider people's real life behaviors, to me that suggests that we should be able to get 10 or 20 kilos if we do this the right way. And that can only be done the right way in an implementation context where you're not so ridiculously adherent to the RCT that you allow yourself to loosen those restrictions a bit to test this the way and design the way that they should be done. So I'll leave you with these presumptuous thoughts at the end. I think we need to get beyond the app, try some different approaches. We need to think about more interesting trial designs, which I'm happy to talk about. We're doing some of that. But ultimately, this is a great area. It's really promising. I think it will change everything, but we're not quite there yet. Thank you.
Thanks, Grady. That was wonderful. How about a few questions?
Within the randomized trial, one of the issues, of course, is numbers. And you have numbers on your side, or the developers of apps have numbers on their sides. It rolls out. You got 10,000 people using it. That's small in the app world, but it's huge in the RCT world. When we talk about trial design and adaptation, and I'm going to try to do an app routine, how am I going to do that with 500 people?
Well, one way is to, one of the approaches that we're using now is, this is a bit of a back-ended way of answering your question, is an approach called MOST, the multi-phase optimization strategy. Basic idea with most is that with multi-component interventions, we often don't know what the active ingredient is in a treatment. So as I've mentioned, we'll throw self-monitoring at you and skills training at you, and we'll do it 4 different ways, and you'll get calls from this person and text messages from that one. We don't really know what the right set of components are. So what most argues is that you first design your intervention, and then you basically test it in a factorial trial. The thing that confuses most people is most people think factorial trials require lots of patients, but in fact factorial trials were developed to optimize sample size considerations. So what you do is that you basically create your intervention components and you figure out which kinds of comparisons you want to make. So for text messaging intervention, I may make a comparison of the frequency with which I'm sending the message, the kinds of response options I'm using, how I frame the feedback, whether or not there's provider integration. I test this in a big factorial trial, and then I use the best performing essentially components in an RCT that would be powered in the way that you would expect. That's one way that we get around the sample size issues. We use adaptive trial design issues, trial strategies all the time. We increasingly are using kind of more rolling recruitments where we basically will randomize patients to receive one version of an intervention, and then when we change it, the next cohort behind them gets the first intervention first, and then the change second. So you can optimize over a longer period of time and be able to test differences in different versions of different apps. But I agree with you. This is ultimately a challenge. I think really we're going to have to this is the problem with the RCT in this context, and is going to require more kind of single case designs, more kind of pre-post kinds of trial designs, if we can get ourselves to accept a different kind of level of evidence.
So Gary, one of the things when you think about using a technology like this across a population, there's tons of different segments.
Yeah.
So to my mind, one of the things that's always been exciting about this is actually drilling down in different segments. Some people like Facebook, and some people like the New York Times.
Yeah.
And so if to be sticky, we have to segment what we're doing. So to some extent, you're showing unsegmented data.
Absolutely.
Isn't the end of the day having 10 different applications and trying to figure out who's gonna be the Facebook solution and who's gonna be the time solution?
Yeah, I think ultimately it's a really good point. I mean, there are kind of 2 ways of thinking about that. There's sort of microsegmentation that you can do in the context of a single app, which actually is what Facebook does, right? I mean, Facebook tries to be something different to each person who uses it and tries to customize itself to each person, and that's sort of minimally effective depending on how you define it. So you can try to figure out ways of personalizing within a given app, and that's actually what we do in our trials. Or you can imagine a scenario where basically you have an app store and people select the kinds of apps that work best for them, the kind of a more traditional approach to segmentation. I'd argue that the latter, which is where I think we really should be, is not exactly conducive to the way that we approach our science. Right? We don't presume necessarily that, I've already told you about the gold standard weight loss treatments, and they are called gold standard weight loss treatments because there's some assumption that this is the way it should be done and the way that it works for most people. If there's one thing to say about gold standard weight loss treatments, it's that they don't work among patients who are at highest risk. Almost none of them do. But nevertheless, we call them gold standard, and then we sort of move on. So I think that there's a kind of a broader issue in the scientific community about accepting this idea that different approaches may work differentially for different patient populations. There is another problem with that, which is that the dissemination considerations then get much more challenging. So I guess if for me, it would be great if we could get segmentation to a level that is beyond demographics. Because I think what we do a lot in this space is that we do different types of interventions for different types of patient populations. Like we do one for rural patients, and we do one for patients in this country or another. And those are really, really hard to disseminate in real-world settings. So if we could figure out what the kind of active psychosocial and behavior kinds of components were, then I think we really have something.
Phenomenal talk, and thank you for coming and sharing. It really opened up a lot of our eyes. The question here is, you're talking to the converted. We're the crew, well, at least not converted on the apps, but necessarily converted on the idea that evidence around this is really going to be key to it. But the reality is, if you talk to the tech developers, they might balk at this. This is us academics worried about evidence. What's going to be the driver for them to say we should spend some time and some investment in terms of actually creating that evidence?
3 things. I think you're totally right. 3 things, though. One is funding. So we're in a place now where startups that have a great idea, that don't have deep pockets, and who need money from VCs or from private equity firms need to think about evidence. Most of the larger VC groups that are investing in commercial startups, early stage ventures, and particularly a lot of the angel groups, the really good angel groups in San Francisco, Boston, New York, they want to see evidence, trial evidence at the start. That's only happened in the last 12 to 16 months. But we get calls all of the time, will you test my app, will you test my app, will you test my app? Because funders want to see evidence these days because they realize that these things aren't going to be used. The second thing is figuring out evidence. We can have hubris around what evidence is, and I have a lot of hubris that you should care about weight loss outcomes as my primary outcome, right? We talk that way: primary, secondary, tertiary outcome, and then there's all the exploratory stuff. Well, it's often the case that the exploratory stuff is the most important kinds of considerations for adoption. And so the case that I often make with colleagues in industry is, let me test weight loss, and for you, we can test enjoyment or satisfaction, right? We can think about a wider range or a more complete kind of composite metrics of effectiveness, and that gets you a little bit closer. But the third thing is this question of engagement. So people may not agree that weight loss should be the primary outcome. Everyone agrees that the engagement is the most important consideration. Will you open my app? Will you use my app? Will you log on to my website? There's no disagreement that that's really critical. And so people who can't get engaged about outcomes will care about that one. And the thing is that we actually have a pretty good story to tell in the scientific space on that. We vastly exceed the normal rates of engagement in industry. And there's actually one fourth one, and that's regulation. That's tricky for all the reasons that I won't mention anything about that because we'll all break down in tears in a bit. But regulation is going to push us to a place where evidence becomes more important than it has been. But I suspect that won't happen quickly, right? We'll still be worrying about devices as being the place where evidence is most important in the regulatory context. But increasingly, when somebody gets the bright idea of creating a rating scheme for health apps, which one works best for whom and when and why, then I think that'll get important as well.
One quick question about context, and you mentioned the variety of settings in which you guys work. Here at Duke, I think there's a lot of community interest in pushing forward these sorts of efforts, but every single group finds themselves recreating a lot of infrastructure. What are your thoughts about sort of creating common infrastructure in sandboxes which do this, not only locally, but potentially other places?
Yeah, we have to get there, and we're working on that right now. So we have a system, and so I lead a center called the Global Digital Health Science Center. We have an in-house platform called Prompt, which is designed to make it really easy and inexpensive for investigators here and elsewhere to come in and create interventions. So if you wanted to create a medication adherence intervention tomorrow that called X number of patients, texted them on such and such schedule, said X, Y, and Z, you could do that in a few minutes with Prompt. So we're creating that now. The problem is that people have sort of caught on that this platform thing is really important, and what I don't want to see is competition in the platform space. What's really nice at Duke is we have a lot of people who are thinking about this, I think all at around the same time, and there's opportunities for us to get on the same page and create some common platforms. The one platform that I think will change everything is ResearchKit, which was released by Apple a couple of weeks ago. That is going to make it much more easy and efficient to reach large populations, mostly for reasons that I think are kind of have marketing value. So what will be very different in a few months is that patients could go onto the App Store and download Angry Birds and then flip over and download my next research study. And I think so the ability to discover new research studies will be as important as the back end, the technological back end that's supporting them. And there are many of us that are engaged in trying to create the links to the ResearchKit platform to make it easy for Duke investigators to use that system when it's up and running in just a few weeks.